I'm Craig Sable, and along with Rachel Sarnacki, Kathy Farrar, and Andrea Beaton, we lead the Children's Global Health Initiative, and today's event is very exciting to us in terms of hearing about some of the amazing work that Dr. Kenyon and Project Hope have done. And there'll be a reception afterwards in the 5th floor at Research Institute for lunch for those of you who are able to join us. And now I'd like to bring up John Walsh, who will tell us a lot more about Dr. Kenyon's work.
Good afternoon or good morning, whatever. My name is John Walsh, and I work with the Heart Institute. And this is a sort of a special privilege for me to introduce Dr. Kenyon, because I think it's next year will be the 60th anniversary of the founding of Project Hope, which was started by my father in 1958. We originally started out with a peacetime hospital ship, which was equipped with a 108-bed JACO-approved teaching hospital. And we would go to country by invitation, and we would, before we went, do a lot of groundwork where we would have agreements with medical schools, nursing schools, allied health schools, technical schools, biomedical engineers. And we go to the country for a year and have training programs on board the ship as well as on shore in all the specialties and subspecialties, including pediatrics, but a lot of adult practices too. And then when the ship would leave, we'd leave behind large land-based programs to continue the educational efforts in the countries that we were working in. We did this for like 15 years with the ship, and then with the Hope ship got retired, and we started more land-based programs, including the building of a children's hospital in Krakow, Poland, and the building of a children's hospital in Shanghai, China. And I guess there was another oncology hospital, I think, in Afghanistan, if I remember correctly. Children's hospital, too. So, and then we started other land-based programs. And we were in Grenada right after the invasion of Grenada. I was on a survey team, and we went in because the Cubans had taken over the health system there, and Project Hope was brought in to reestablish the healthcare system in Grenada. And Tom was his first venture with Project Hope was in Grenada with his wife. He was a young man back then. He then went to Swaziland for Project Hope, where we had another program, and then following that, I think he went to get his public health credentials at Johns Hopkins, then moved over to Chicago as a CDC director in Chicago, and then eventually went to the CDC, where he spent 21 years doing several things, but I think he was the, I'm reading here, he was the Director Center for Global Health, where he was responsible for overseeing the work of 4 global health divisions, 65 countries. He also spent a lot of time in Africa with AIDS and during his years. So Tom, Project Hope was lucky enough a few years ago, I think it's 2 years ago now, to lure Tom back from the CDC to be the president of Project Hope. And Tom is taking Hope to new heights. Recently, Hope is heavily involved in all the different hurricanes in the United States, as well as Puerto Rico, where they still have several teams trying to help out in those areas. So Tom, I think, is going to come up here and give us, the other thing I have to say is that Tom got into public health. He told me, he can tell you better the story, that he was basically thinking to be a cardiologist, which a lot of people here are, but he was after this woman who was basically going to be his wife, and he therefore went into public health to stay with her. And so we're all lucky that we have enough cardiologists. We're lucky that he got into public health. He and his wife adopted a child from Grenada when they were in Grenada, and then they adopted a child from Swaziland. And both are now accomplished in their own right and out working in America. So Tom has got a lot of stories to tell, and it gives me great pleasure to introduce you to Tom Kenyon.
Thank you, John, and many thanks to Dr. Newman and Dr. Sable for the opportunity to be here with you today. What I propose to do is look at all of global health at kind of the 20, 30,000 foot level, just to give you a taste for the many challenges that we're all confronting each and every day, and hopefully to, even though it might seem overwhelming, to give you some optimism that we can make a difference. We have made a difference. We are making a difference, and we continue to make a difference. But it takes investment, it takes leadership, it takes evidence to drive what we do, and it takes, most importantly, in global health, country ownership. So I thought maybe let's kick it off with a definition of global health, because global health is, when I was training, was not a common term, but now every university almost has a global health center or global health activity. There's degrees in global health. There's ambassadors down the road in global health. It's one of our diplomatic tools. It's huge in the private sector, obviously, that has commercial but also philanthropic interest in global health. So, but I start off by saying all health it's really local. When you have your global health encounters as you do overseas, it's really about the local health situation. But global health is really about collaboration. It's about country ownership. It's about more than local. It's transnational. It involves research and action for promoting health for all. Health for all, you may recall, was a UN aspiration when I was getting started, and kind of what got me motivated to get into this movement. We were supposed to have health for all by the year 2000. I think we missed that. But now we're trying to have health for all by the year 2035 through the Sustainable Development Goals, which I'll cover in a moment. So just as John alluded to, this is how Project HOPE began. In some ways, how global health engagement began. This was in the 1950s when President Eisenhower donated a ship to John Walsh's father, who was President's cardiologist, one of them. And the President had a heart attack, and Dr. Walsh was part of that team. Anyhow, the President was moving forward with a people-to-people movement, sensing that the rhetoric around the Cold War was really revving up, and we needed to have some more international engagements to soften the tone of that. And so the exchange student program arose out of that effort, and then Project HOPE arose out of that effort on the health side. And I think it's arguably we still need these global engagements so that people, we're getting more and more polarized all the time. So I think there's still a place for this type of engagement with partner countries and people to get to know each other across cultural and ethnic lines, so we build trust and friendship worldwide. But we also learned from the teaching hospital ship that the SS Hope was, which was scrapped in the mid-70s, we're now land-based, was the importance of working with a counterpart, always going in there to help them realize their vision. Yes, we can have our own vision, but it won't work if it's not owned at the local level. And so when I joined Project HOPE, I had this drilled into me, who's your counterpart? And when I came into government, because I found it immensely successful, if you engage with a local peer who's really trying to get something done but needs some help. We did this in Grenada, reactivating the nurse practitioner cadre that had gone dormant with the infusion of Cuban physicians who were very good, but they had to leave, and left with nurses that could very well cope with the day-to-day issues that children encountered and create referral protocols. So that was something they wanted to do. So we worked with them to do that. And when I was engaged with CDC for so long, we developed the idea of co-location. So in many of my country assignments, I was co-located in the Ministry of Health, usually the Communicable Disease Division or the TB Division, to work side by side with my peers. It doesn't work if you're off in a tall office building that's air conditioned behind a lot of walls and fences like our embassies are now, which eventually happened after 9/11. It was harder and harder to work alongside your peers, but just to make the point that your first objective in a global health engagement is to find out what's that local vision and how can I be helpful. So Project Hope has always worked in a number of program areas. Maternal child health is a major one, but again, we need to focus on what is it about maternal child health where we can make the biggest impact. Non-communicable diseases, our major areas in infectious disease are HIV and tuberculosis. We're also responders to disasters such as the recent hurricanes, but we just send in medical teams. We don't do what everyone also needs in terms of housing and food and shelter and all of that. We focus on the medical response, but doing that in partnership with the Ministry of Health. We don't put down our own flag. We always co-locate with health ministries. And our main contribution to health system strengthening is the health workforce. And that's many different sizes and shapes: pre-service training, in-service training, community health workers, mid-level workers, specialists, again, whatever the country is aspiring to do, but also what we can mobilize resources for. And then very importantly, HOPE also publishes the journal Health Affairs, which is more around domestic policy, but increasingly we're seeing domestic merge with global, but it's probably the leading journal in its field. So we currently work in 26 countries with 54 programs in those categories that I described. Last year, we reached over 1 million beneficiaries, trained over 100,000 health workers, mostly in-service training, and mobilized over 2,000 volunteers. And more our volunteers are local from the community where they are familiar with the culture, the language, and the needs. But obviously, when we need special expertise, we can bring in outside volunteers. And we also mobilized more than $100 million of donated supplies and equipment. So that's HOPE. Now let me turn to the global health challenges. And when I came to the Center for Global Health and from the HIV team, suddenly you're confronting the whole world with everything. And what does a public health agency do in that respect? So I found it convenient to create these 3 buckets that I call, on one hand, the unfinished challenges. These are the things we've been aspiring to do for decades: ending maternal child mortality, or at least preventable mortality, addressing HIV/AIDS, TB, and malaria, family planning, maternal mortality in terms of obstetrical emergencies, and you name it. There's a litany: polio eradication, vaccine preventable diseases. We've been doing things for decades, but we haven't finished the job. So many of those are still embedded in the Sustainable Development Goals. Number 3 is health. And these are real important drivers at the country level, including our country, because the U.S. is also a signatory to this, what is essentially a UN treaty, that we will commit to this as well. And embodied in number 3 is universal health coverage. And the U.S. really couldn't sign on to that until we had the Affordable Care Act. So it all came together nicely a couple of years ago. I'll leave it at that. But the important thing is these are important drivers because governments will be accountable to the UN in 2035 to achieve universal health coverage. And so this is a very important endeavor for health ministers to advocate with their finance ministers and their foreign ministers that they need to elevate all of these Sustainable Development Goals, but in particular health ministries, to highlight the importance of health. I kept non-communicable diseases separate because that is obviously there's an avalanche of NCDs, and you know, I'll go through some of this, but countries are, in fact, the least equipped countries are really being confronted on unprecedented levels with NCDs. And then there's the disasters and emergencies, which are growing increasingly complicated and protracted. This is the way we look at global health engagement at CDC as a public health agency, as a public health system developer, epidemiology being the science of public health, surveillance and health information systems being the major tools of epidemiology. So this is to develop evidence, to identify risk factors, and why are we having these conditions, so you can design appropriate programs to implement, and prevention being the mainstay of public health, but also intervening in other ways. Treatment of TB is treating TB, but it's also prevention. Treating of HIV is treating HIV, but it's also prevention. Research, but different types of research. This isn't necessarily bench research, but more of operational research or intense monitoring and evaluation, because the effectiveness of any intervention in the field is a function of its efficacy, but also the coverage. So in a public health environment, you really care about coverage. It's easy to have evidence-based interventions, but how do we reach the population at scale? And that's really the ultimate endeavor of public health programs. The workforce in public health is a bit different than we have in the clinical setting. I'll go through the health system strengthening in a minute, but epidemiologists, social scientists, economists, sociologists, and laboratory workforce, part of the workforce that we don't normally think of in health necessarily. And then the laboratory, again, for public health concerns, not necessarily molecular aspects unless it's a public health issue, but laboratory to address the issues of public health significance. And then all of that feeding into the development of public health institutions. And increasingly we've seen, we take these for granted. We always have had state health departments, the CDC and so forth, but many countries are waking up now and seeing the need to split off the public health function from the operating of the health system. They're interrelated, but a different set of issues and priorities. And a lot of our evidence-based public health actions are linked to policy and legislation and regulation, which not necessarily the health system is doing. So this is a framework for public health system strengthening. And this is WHO's framework for health system strengthening. And I put up here, should we follow a health system strengthening approach or a disease response approach, or what some refer to as a tangential approach to addressing today's global health challenges? And when I was assigned to the State Department in the early days of PEPFAR, I don't know if you know PEPFAR, but it's the President's Emergency Plan for AIDS Relief, and I was also the Chief Medical Officer, we were often being challenged, understandably, by the rest of the global community. You know, why are we investing in HIV when we should be investing in strengthening the health system? And the Institute of Medicine did a very elaborate review of our approach, and we were gratified with their conclusion, which they came up with independently, that we were really invoking a tangential approach. In other words, we were approaching HIV/AIDS, which was and still is a crisis, but in a way to build the health system for other things. So if we strengthen the supply chain for diagnostic tests and antiretrovirals, we can also do that for antibiotics and other medications. If we develop a workforce for HIV, we can also ensure that they cover other issues. So when you're approaching a program in a country, you can't build capacity of the health system without addressing one of these building blocks, and none of us can do all of those. None of us can do all of those. There are certain partners that are great at healthcare financing. Obviously, information and research is a specialty. Oftentimes, we're dealing with service delivery as partners, trying to transfer skills or improve service delivery. For Project Hope, our focus is really the health workforce. Because in the encounters I've had, often with health ministers, their priority is just help us build our capacity. And 9 times out of 10, what they mean by that is build their workforce. So this is just an overview of health systems, public health systems, and I'll get more into the specific health challenges. But first, just remind ourselves that we do face a health worker crisis. We're just used to it, and that's why it doesn't seem like a crisis. But I'm sure in your country encounters you've seen the dramatic shortage of healthcare workers. The good news is with the Sustainable Development Goals, it's projected that 40 million new health worker jobs will be created. That's great. That's good for the health system, for health as an economic driver, as an employer, even addressing gender inequities, which we know are still a major issue. 66% of health workers around the world are women, and in many of the countries in where we operate, it's even higher. But you can see we face dramatic shortages, and the whole success of the Sustainable Development Goals are really threatened by this health worker shortage. And there's a lot that we can do as actors to help countries address this. So going forward, we face a lot of new challenges in global health, and this is global health adapts to the world, not the other way around. And for the first time, we have more people living in urban than rural areas. So urban health is now a specialty area that countries could benefit from. More people are overweight than underweight, and that's global. That's not just in high-income countries. We have more deaths among adults than children, and I'll show mortality tables in a moment. NCDs kill more people globally than infectious diseases. By 2020, which is almost tomorrow, NCDs will kill 4 times more people than infectious diseases. And the highest rates are cropping up in the countries least able to cope, in the low and middle income country, and this is a real threat to their development. And then lastly, and there's more than I've listed here, I ran out of room, but the number of low income countries has been cut in half since 2000, which is great, but it's very deceptive because many of the countries that have moved into middle income, particularly in Latin America, still have major pockets of poverty that continue to drive disease. But a lot of the development assistance that we as organizations and also your institution would benefit from in terms of grants has really dried up in countries that have reached middle income, but yet they need support in addressing those major pockets of poverty and the diseases that accompany them. So I'm a fan of David Letterman, so I know he's forgotten past, but this was my top 10 list of what needs to be done in global health. And this is very broad, probably very obvious, and you may have other issues to add to this list. I don't pretend it speaks for everyone, but obviously ending preventable maternal, neonatal, and child mortality. Huge progress in this over the last 20 years. Child mortality has been cut in half, but as I'll speak to in a moment, there remain major problems to be addressed. We've established new TB global targets, basically to end TB. We're on the verge of controlling HIV. It's very, very promising. We need to end preventable mortality, and that's mortality in people less than 70 in the NCD speak. And trauma, which has been a major growing issue, particularly as economies come up, motor vehicles are increasingly available. In Namibia, where I was assigned, single vehicle road traffic accidents was a leading cause of death, just because of speed and alcohol and lack of a trauma service to bring patients to centers. We need to prepare for and respond to global epidemic and pandemic threats, and we've all seen that with Ebola, but Ebola was just a warm-up to what could really happen, and many other examples. We're also needing to respond to increasingly complex needs, disasters, refugees, and now climatic changes. What's the impact of those going to be on global health? Capacity of healthcare workers is of paramount importance. Building capacity of local partners, not ourselves. We'll build our capacity depending on how much we build capacity of local partners. And also, there's a need for precision global health, just as you're having precision medicine, we need to target our interventions to the greatest sites of disease incidence, disease mortality, and addressing the right risk factors to make a difference, and I'll show some examples. And lastly, to fill the healthcare financing gaps. That's not only national systems for healthcare financing, but the global architecture for supporting global health financing. It's inadequate in spite of the major investments. It's unreliable because it usually requires, in the case of the U.S. government, an annual appropriation, which is always in jeopardy, and it's not sustainable. So ultimately, you need a solution, a financing solution for these programs to sustain and be brought to scale. So I go back to what motivated me to get more into global health, because as a young pediatrician working in an African hospital, there was obviously no shortage of mortality, and I was overwhelmed by how do we address all these deaths from measles, neonatal tetanus, H. flu meningitis, et cetera, et cetera. And at that same time, this UNICEF executive director, James Grant, was pioneering this approach under this child survival and development revolution called the GOBI strategy, which is obviously very simple and straightforward. Doesn't need a pediatrician to do this: growth monitoring, oral rehydration, breastfeeding, and immunization. And this is just this simple set of interventions is credited with saving 12 million lives by the end of the 80s. And it was due to having, a sound problem defined, mobilizing leadership, and it wasn't just Mr. Grant. It was diplomats around the world. It was health ministers all getting behind this through the UN system. And, success breeds success. They showed this could work. It attracted investment, and it's continued to attract investment into addressing child mortality. But this is what global health needs is leaders like this to stand up and take a stance on important challenges. So this is just an update on the state of global mortality. These are the various age groups across the x-axis and the number of deaths in the millions. And then this is 1990, and then this is 2013. So this is the under 5 age group, and you can see it was a major cut in half, again through strategies like GOBI, but other interventions, including uplifting of socioeconomic standards in countries over that 20-25-year time span. But as you can see, these color bars are geographies. In the gray is Africa. Even though there was decline, you can see there wasn't as much decline in child mortality in Africa over that 25-year period. But look at Southeast Asia. They went from this slice to this slice, and South Asia from here to here. So there's been tremendous heterogeneity of advancements, and there remains tremendous heterogeneity of challenges. And I won't talk about the other age groups, but the good news is more and more of the world was surviving into their later years. That's what's supposed to happen, right? So if you map it out, 24 countries account for 3/4 of global child and maternal deaths, and there's probably no surprises there. So this is where it's not that child mortality is unimportant anywhere. It's important everywhere, including here in Washington, D.C. But in terms of global investment and attention and innovation and leadership, these are the areas where it epidemiologically cries for doing more. And this is the estimated projection of causes of mortality. We still have 15,000 deaths a day, which I think we would all agree is unacceptable. And it's guesstimated at least half of those are easily preventable through either immunizations or easily treated conditions. And I'll come to the neonatal, it's even higher than that in neonatal, but the top 5, pneumonia, diarrheal disease, premature birth and resulting complications, intrapartum events, which is, of course, asphyxia, sepsis, and diarrheal disease, and malaria. I'll show some success stories with malaria, but that still remains a major child killer. So 15,000 deaths a day, including 7,000 newborns. And the newborn portion is becoming a bigger piece of the pie of child mortality, because the child deaths are coming down, but the neonates aren't coming down, of course, in a corresponding fashion. What's happening is countries are reaching a certain level of neonatal mortality where to make further advances, they need intensive care units. And we're trying to tackle this. For example, in the Dominican Republic, 75% of under 5 deaths are neonates. And for a lot of reasons, including very high rates of teen pregnancy, but in a particular hospital, it has 12,000 deliveries a year. If you do the math, that's 38 or some a day. That's a lot. They have 4 NICU beds, and some of those don't have monitors. They can ventilate, but they can't monitor. So what's the right technology? And there's no neonatology fellowship. There's no neonatal nurse fellowship or training. So there's a workforce solution. There's a technology solution. There's also a public health solution in terms of preventing teen pregnancy. But in the meantime, so this is where the country wants to go, and there's many other examples like that. As neonatal mortality comes down, we're going to have to find the right package, and people are working on this, of intensive care. But intensive care can just be thorough monitoring of temperature, glucose, oxygen, signs of sepsis. You know, it doesn't have to be ECMO and ventilation. You know, that obviously plays its role, but there are some basic things that we can even do intensively in the care of newborns. So, and this is just a visual depiction. 2.6 million babies die in the first 28 days of life. Top 3, these account for about 80% of neonatal mortality, and we can do this. We can do this. It's just I'm not sensing the world paying a lot of attention to this. It doesn't have an advocacy group for it. There's nobody going to the UN saying, you know, save our babies. But I think this is the kind of effort that we have to have a galvanized response around, and I think in order to realize success. But I think it's very approachable, it's very doable, and most importantly, countries want to move in this direction. So just what is malaria programming done to address all child mortality? Because it's often difficult to tell cause of death, especially from malaria. But you can see what happened to all-cause mortality in children under 5 over this time period. And I had dinner last night with the head of malaria and AID, and he said, I wish I could have updated your slide because it's come down even further. This was up to 2011. But you can see major declines, even in Angola, which has a highly dysfunctional health system, with the introduction of a comprehensive malaria program, which is basically 4 things: bed nests, testing, which you can do with a rapid diagnostic test, the appropriate antimalarial, preferably artemisinin containing antimalarial, and indoor residual spraying. Four simple things comprise malaria programs. But you can see major declines in all-cause mortality in children just from introducing a malaria program. Polio, on the verge of eradication. At the dinner last night was the head of polio eradication at CDC. There's only been 11 cases this year in the world, wild-type virus, all in Afghanistan and Pakistan. How are you going to get vaccinators into Kandahar and difficult places? So nobody would have projected, I think, when the world, through the UN, committed to polio eradication back in the 1980s, that we would be held up by conflict and terrorism. So anyhow, the world is inching closer and closer to polio eradication. But this is one of the case examples of, do you invest in a cause or do you invest in a health system? This has cost billions of dollars to get to. And obviously the polio eradication team is on one side of that argument, the health system strengthening team, because most of this has been accomplished through campaigns, not necessarily propping up the healthcare system to deliver routine immunization programs. So nobody denies that that's unimportant, but nobody could afford to wait for programs to work to reach polio eradication. So this has been one of those examples that cause our health system. So now there's a lot of effort in transitioning polio, whatever the remaining aspect of immunization will be, to the routine immunization program. But this was the last child with polio in India, which was a phenomenal accomplishment, and led by the Indian government with lots of partners. But billions of dollars have gone into this. The Gates Foundation's put billions into it. Congress, we led this on behalf of the U.S. government at CDC, deploying hundreds of epidemiologists to track in laboratory networks to run molecular subtyping to figure out where is transmission coming from, and really what we call shoe leather epidemiology to track down the last of the cases. But, sorry, I had measles. Maybe it's coming later. Well, this is, I was going to talk about what's happened with measles reduction. Again, we've saved about 11 million lives over the decade up to 2011 through measles vaccination. But is that on the table for eradication? And this is just showing immunization coverage rates by GDP, socioeconomic status, sorry. And you can see some notable countries, including ourselves, are below the threshold for herd immunity because of the anti-vaccine movement, if that's the right word. So the prospects for measles eradication, though biologically possible, I think some would question whether we would actually get there. And is it worth diverting the billions into that, or do we strengthen routine immunizations to keep disease levels to a minimum? That's open for debate. But I can tell you that there are no plans in the pipeline to eradicate measles, but there are groups that feel it's biologically possible because we have a highly efficacious vaccine and other things in its favor. There's really no reservoir. We know how it's transmitted, et cetera, et cetera. So moving on to HIV, and here there's been extraordinary progress over the last 15 years in particular with the introduction of antiretroviral therapy that wasn't available long into the epidemic. Antiretroviral therapy really took off in 2003, 2004, 20 years after the first recognition of HIV as published in the MMWR. So now we're at this phase where the UN has established targets by 2020, which is not far away. We want to have identified 90% of all people living with HIV, identify them, get 90% of those identified as positive onto treatment, and achieve viral load suppression in 90% of those on treatment. So if you do the math, that comes to 73%. And that would then, and this has all been modeled, would successfully lead over time to 95, 95, 95 by 2030, and lo and behold, we've achieved epidemic control. So this is within reach, and it's taken, again, billions of dollars, decades of effort, lots of leadership, and the U.S. leadership came from our president, and this became hot on the diplomatic efforts, but it shows that with leadership investment and hard work, we can make substantial progress. But just to make the point about all health is local, it's really local in the case of HIV. And for years, we were doing these blanket programs without targeting epidemiologically where is incidence highest, where is mortality highest. And we didn't have incidence assays. It was a guesstimate of incidence. If you looked at HIV prevalence in the 15 to 24-year-old age group over time, which theoretically would be recent infections, right, if they're young. That was the tool we used. Now we have incidence assays that can tell you the percent of infections that happened in the last 100 days. So now there's very thorough but very expensive surveys underway at the population level to really drill down. And Kenya was one of the first countries to do this, and showing in these districts or counties, in the case of Kenya, outlined in red, these account for half of the epidemic. So we should be focusing there. But for 20, even 30 years, we were doing everything at once. Not to ignore the other counties, but to make our investment proportional to the disease burden. So there's a big push for this, and that's a big part of the 90-90-90 aspect. Also understanding your epidemic, these are all the different regions of the world, and the light tan in East and Southern Africa, 79% of their infections are coming from the general population. They're not necessarily key population groups. But if you look at other parts of the world, Eastern, Central Europe, Asia, it's a very different picture. Most of their infections are happening in key populations. So the program you design for one geography isn't necessarily going to work in the other geography. So you have to follow the local dynamics. And I think that's self-evident. But again, for years, we were just doing a shotgun approach without tailoring it to local needs. But, just to display some measure of success, these are survival curves. The epidemic beginning in the 1980s, and you can see where life expectancy plummeted in Botswana, Kenya, Lesotho, all these southern and East African countries, South Africa, that were part of the hyper-endemic areas. But with the introduction of programs and intensive effort through both the Global Fund and PEPFAR and other local investments too. I mean, we have to recognize what the countries themselves have done. In the case of South Africa, they're investing $2 billion into their own epidemic. And as countries witness progress, they put more and more of their money in. So you can see a return, hopefully, of life expectancy, and hopefully that will continue to increase. But the effort will need to be sustained. HIV is not going to go away. It will need to be sustained and continue to be monitored closely. And then this is a global TB plan, and TB now is the leading infectious disease killer, around 1.4, 1.5 million deaths, overcoming HIV. With that, deaths have been cut in half because of treatment. New infections have been cut in half because of treatment. Treatment's prevention. But the TB is trickier for reasons that we all understand: latency, respiratory transmission, partially effective vaccine, et cetera, et cetera. But there's hope and optimism for new tools. So if we just leave the current state of affairs alone, it's only going to creep down by 1.5% per year in terms of the decline in the case rate. If we accelerate and optimize use of current and new tools emerging from the pipeline, hopefully get a vaccine by 2025, we can push the curve down further. So this is what the global TB community is aspiring to do. There's a high-level meeting of health ministers in Moscow next month to elevate the importance of TB now that it seems to be on the increase, and identifying certain populations. At Project Hope, we have a program in Central Asia, particularly on migrant workers coming to the extraction industry. TB case rates of in excess of 3,000 per 100,000. That means 1 in 30 have active TB, and 15% have primary MDR resistance. So there are pockets of around the world that need special attention and directed action. Now, to turn to NCDs, they're obviously very disproportionate mortality rates. Again, a lot of this having to do with the health systems being weak and not having the means to respond. But in some countries, not even having the basic understanding of what they're dealing with and dynamics around this escalating crisis. So I'm just going to throw out a couple of examples. We're not going to see public funding on the global stage, I don't think, at any substantial level like we've seen with HIV, TB, malaria, maternal child health for NCDs. So this is just an example, and I throw this out here about just to exemplify the partnerships that are coming up. This, in the case of my former boss at CDC, Dr. Frieden, who mobilized 3 foundations, Gates, Zuckerberg, and Bloomberg, who have a lot of funding, to give attention to hypertension, which is the biggest killer other than tobacco, and highly neglected, silent, and this actually relates to children, because the best thing you can do for children is to keep their parents alive, right? Especially in low-income settings. And I had an instance when I was based in Ethiopia. I needed to see a physical therapist, and I happened to ask him, well, what do you see most of the time? He said, strokes in 40-year-olds. So this has been an explosive problem and pretty easy to address. You can treat hypertension in these settings for $15 a year. It's not a high-cost item. Obviously, to get a program in place, the costs are going to be more, but the treatment doesn't need to be. So I just throw this out there as a innovative partnership around a specific cause. It's not supporting development of the healthcare system. And my challenge on this is, are you going to have the workforce to do all this? It's easy to pick up hypertension in the community, but are you going to link them to a facility? If you link them to a facility, are you going to keep them on treatment? Are you going to achieve control? It's going to take a workforce to do that. A similar example with cancer, we just announced a few weeks ago, led by the American Cancer Society. They convinced Pfizer and Cipla to make available 17 chemotherapeutic agents at cost. Cost being the cost of production and packaging, not R&D and all the other things that get packaged into cost. And so that's a positive development. It's somewhat reminiscent of what preceded HIV treatment. And so maybe this is the start of something. IBM Watson will help scour the evidence and the guidelines around the world to come up with standard treatment regimens, because to take these programs to scale, you're not going to be able to depend on specialists. There are 30 oncologists. This is targeted to Africa. There's 30 oncologists in Africa. So much like we found with AIDS treatment, where we started with doctors, before long it was task shifted to clinical officers, to nurses. 90% of the AIDS care in Africa is now done by nurses. They initiate care. It's only when there's suspected failure or complicated opportunistic infections that a physician comes into play. So just throw these out as 2 very innovative, creative partnerships, and if you want to make progress in this space, this is probably what one will have to come up with. So turning lastly to pandemics and epidemics and something called the Global Health Security Agenda, which I'll close with describing, and I was somewhat involved with in designing in my last years at CDC. And, you know, I think it's self-evident epidemics can create insecurity, but we're always nervous in the health world when we talk about security, because when you get in the room with security people, they have a very different perspective on things than public health people. But it is called Global Health security at CDC, when we were naming the division, we'd call it the Division of Global Health Protection rather than security, because we're not a security agency. Anyhow, lots of debate about what to call this, but clearly when things get really bad, it is a security issue. When you can't govern, when you can't police, when you can't mount an army, as was the case with HIV. With HIV, it was declared a global health security issue because African armies, it took 4 battalions to mount 1 HIV-free battalion for a peacekeeping force. So that tells you if they can't do it, somebody's going to have to, and the world was frightened by that. So that honestly is what led to HIV. It wasn't the 25 million deaths that had occurred by then. It was that it was really a threat to the ability to maintain security. And of course, Ebola, which was very scary, very fast, very dramatic, quickly led to an unraveling of the ability for the West African countries to govern themselves. But I say only 11,000 deaths, that's a lot. But during that same time period, we had 3 million deaths from HIV and TB. So it obviously was big in the headlines, but not as big as a killer as other things. So these are just the 2 instances where the UN Security Council, the 15 members, have voted to make HIV and Ebola global emergencies, and some of the quotes that officials made. So, and this is another reason to, we've all probably seen this photo of airline routes, and, a case today can be an epidemic in 24 hours somewhere else. So major globalization. And what really prompted us at CDC a few years back to put forward this global health security agenda, which later became a diplomatic agenda, was the report by WHO in 2012 that only 16% of countries said they could conform with the international health regulations. The international health regulations, or the IHR, it gives a formal treaty to which countries can be held accountable, but through self-reporting. There's no independent external evaluation, which is inherently problematic. But this was obviously alarming. We had, at the time, Middle East respiratory syndrome was cropping up, and we didn't understand transmission and lots of other aspects, and all of these growing concerns on the escalating graph here, and the potential for re-engineering and the rise of drug resistance and so forth. So it was a convergence of the finding from WHO and all these incidents, and then Ebola. The initiative was actually launched in February of 2014. Ebola only made it obvious why we needed this, and this is also when Africa mobilized its CDC for the first time, and I had the privilege of being involved with development of that. So this is just what West Africa looked like in October of 2014. That was in the middle of the epidemic, and it's hard to make out, but these are the Ebola treatment units that were in existence at that time, but you can see how much of the countries had no place to place patients, and hence major transmission to others. And so Ebola just reminded us, and this little guy, I think it's a girl though, remains a major issue. Again, with climatic change, we are very likely to see a rise in vector-borne diseases, and then of course you're all familiar with Zika, which became a issue of public health significance, but never an emergency. We could debate that as pediatricians, but because of the mortality not being, as we had seen with others, no unraveling of the security system, et cetera, it really got off to a sluggish start. It took 9 months for Congress to appropriate resources towards this, diverting leftover Ebola funds in the meantime, not optimal, and hence the argument that there should be an emergency fund sitting there that somebody's given the authority to push the button and release those funds, and we don't have to go through another argument and appropriation process to do the right thing. So DECA was not the best example of response. So the Global Health Security Agenda, and this is where I'm closing, the model we came up with was a prevent, detect, respond to make it understandable by the public, by diplomats, and not just the public health community. And I think these are obvious statements, but contain these action packages around prevent, around detect, around respond, and then further cascades down into what should be in place for a country to be coping with antimicrobial resistance. Do you have surveillance? Do you have antibiotic control measures in place, et cetera, et cetera? Are you linked with the zoonotic disease community, et cetera, et cetera? So this is now in place, in play. What's underway are joint external evaluations, usually by government actors, but also civil society, evaluating national programs against these parameters and coming up with action plans. The worry being there isn't funding necessarily to address the findings of the evaluation. So, and many of the weakest countries are the ones that are least able to take corrective action. So this is a movement in the right direction, but it just is a reminder that we simply aren't prepared to cope with a major pandemic. I think that should be abundantly clear, and so there's going to need to be greater emphasis on this in the future. So just to close, you know, and this may seem self-evident, but we're not going to get anywhere in global health without partnerships. And for us at Project Hope, the fundamental partnership is with the in-country entity, the training institution, the host hospital, the host Ministry of Health, and then our other partnerships evolve out of that. But you can see many players are key. We can see many examples of these partnerships moving initiatives forward. But again, it boils down to the country also wanting to make a difference with their own population, wanting us as partners to help build their own capacity so they can realize their own vision. So let me stop there and hope I still have a little time for questions.
I have a question, Dr. King. Thanks for the presentation and closing on partnerships, and that's something that's kind of thank you for the presentation and for closing with the discussion about the partnerships, because I think that's something that interests our group right here. In Washington and probably all over the country, we're finding universities and public health schools and medical schools that now have global health tracks. And so I was wondering, are those tracks coordinated? Should they be coordinated, or should be left sort of like the capitalist free market where the best program comes up? And then to bring it back to children's, are there, I see this Washington, D.C. as a town where we could have great partnerships through all the international agencies and federal agencies and the universities. And what are your thoughts on, in a town like this, some institution arising and taking leadership, maybe not total leadership, but, you know, guiding the collective will in a community to address some of these things, as opposed to fragmenting and inefficiencies and redundancies? Yeah,
that's a great question. And, you know, I think some might disagree with me, but Washington, D.C. is probably the capital of global health, you know, for obvious reasons. But some might say Geneva, some might say, but there's a lot that happens here. The bank is here and many other players in global health. So you're in the right geography. Are you familiar with the colleges and universities in global health, CUGH? No, I think that was created out of this recognition that institutions were coming up with Centers for Global Health, and there was an interest in sharing of ideas and making it better than that, sharing of programs, sharing of responses. So that's a venue for that. I don't have personal experience because we're not a college or university, but I used to go to their meetings on behalf of CDC. But it's coming up with that innovative approach, I think, that will attract investment. Having those in-country relationships that the most flattering statement that everyone ever said to me in the field was, we like working with you because you're here for us. You're not here for you. And I think sometimes in sitting in health ministries and seeing who they were meeting with that day or trying to work with, they'll be very receptive to those that are there to help with their problem. There's an understandable hesitation if you come in with a preset agenda. So any institution, I think, is trying to get anywhere in global health, I would urge them to have those relationships and build on those relationships. And there's a lot you can do without a lot of money in global health. We do a lot at Hope with volunteers. The ship, now it's a long time ago, and John can tell you more because he ran it. It was staff and volunteers. It was supplied with donations. It was equipped with donations, and so there is a philanthropic spirit, I think, is still out there. But philanthropic support is shifting. The super wealthy are becoming, obviously, have become major players in this space. People moving into their 50s, which is usually the highest donating age group, mid-50s, mid-60s, kids are out of school, they're closing their careers, they've saved some money up, let me do something good. That group has been shrinking, and people moving in their 50s isn't going to be back to highest levels until 2045 or something like that. So this group of major investors has become and will become the most important group to reach if in terms of looking for philanthropic support. Colleges and universities are major players now, and that's a good thing. It's just how to have at your institutional level the right engagements at the country level. Yes.
Richard Jonas, proud to be a Hope alumnus.
Thank you, Dr. Jonas.
When we first started going to China, we encountered the problem of physicians in whom we'd invested a lot of time and effort and trained them, and then suddenly they would disappear from China and show up in the United States as a physician in the U.S. So how much of a problem, and what do you feel we can do about the issue of doctors from third world countries being recruited to developed nations who are underinvesting in the training of physicians?
Great question. In fact, we're talking about with Dr. Sable and his team about the situation in Uganda where they've trained cardiologists, but they've actually stayed. And what I found with the physicians I saw move on, it was more a dissatisfaction with their working environment than their salary. The salary is important, but it wasn't everything. I met with the head urologist in Ethiopia, been practicing for 25 years, and makes $500 a month. So he has to have a private practice on the side to put a roof over his head, put his kids through school, put food on the table, et cetera, et cetera, et cetera. So I think there needs to be some allowance for that if the government can't meet expectations. But as I tried to say with the health worker crisis, I think it's actually going to get worse before it gets better, because there's going to be, or there is, an open market for health workers worldwide. When I was stationed in Ethiopia, they made an intentional effort to open 15 new medical schools almost overnight to export, reach a point where they would now export physicians rather than just keep them for their own service. So they went from graduating 200, I think, graduates to 2,000 within, but I can't vouch for the quality of that education, and that's another. So the supply side is very much going to affect the answer to the question you raised. But what we can also do, though, is train health workers who are going to stay. Community health workers, which was a dismal failure in the 80s, and I didn't cover that, we depended on them as volunteers. That didn't work. It wasn't enough to give them an incentive. So now many countries are starting to create a cadre of paid community health workers. And again, Ethiopia is a great example where they have one community health worker called a health extension worker for every 500 households, times 5 per household for one, so one health worker for 2,500 population. And they cover them with 16 health interventions, public health interventions, you know, malaria, family planning, immunizations, et cetera. And they're paid $30 a month, and they're very happy. And they're in their community, they're not going anywhere. But they also give them a career structure where with more education they can become a nurse, maybe a doctor, et cetera. So I think that's probably one way to approach this. Now to reach your level, the specialist level, that's where it's going to be harder to keep people. But again, I think if they can offer an acceptable compensation and flexibility to achieve that compensation, but more importantly, have a productive work environment, I think people will stay.